And now, ladies and gentlemen, we now come to one of the highlights of today's MedTour Connect session, our educational workshop. And it's my great pleasure to introduce Dr. Irving Stackpole, President of Stackpole and Associate Company. He is internationally recognized expert in healthcare marketing, business development, medical travel, long-term care, and senior service. He has helped healthcare organizations around the world. As a highly respected international speaker, he has delivered keynote presentations and workshops. Today, Dr. Irving will lead a workshop on digital health and telemedicine integration, and he will explore how digital technologies and telemedicine are transforming healthcare delivery and strengthening international collaboration and also enabling healthcare and medical tourism providers to connect with patients across border more efficiently than ever before. Please join me in giving a warm welcome to Dr. Irving Stackpole. Dr. Stackpole, the screen is yours. Can you hear us?
Yes, I
you're
can. And while I may be expert in several areas, I'm apparently technologically challenged today. I hope that very soon my screens will pop up. Here we are. Well, thank you, Dr. Farani, and thank you all for sticking around. I see that over 30 people have stayed. Let's see how many people are here at the end, because this is very different from the type of presentations that you've been listening to. I think what HTDC does in presenting these forums is really outstanding, and I am honored and appreciative of being here. And also, again, fair warning, this is very different. So I've been working in this space for a very long time and have a deep vertical understanding of medical services, cross-border trade in many places around the world. So I'm going to offer you my perspective on the emerging digital and artificial intelligence implications for cross-border trade in medical services. So first of all, cross-border trade in medical services is what many of you have been referring to as medical tourism. Medical tourism, as such, isn't an industry, it isn't a sector, it's a set of vertical markets that are highly fragmented and highly regionalized. And this is important in understanding this so that you can tailor your service offering and your demand management to the particular vertical and the particular region in which you're operating. So I'm going to try to manage my slides here. So the digital trade in cross-border medical services is changing the markets for cross-border trade. The digital services cross borders far more easily than patients do. Patients and consumers traveling from a destination to another location are, of course, constrained or limited by the transportation infrastructure and by many other geopolitical factors. Visas, access, unfortunately these days, all too often, conflicts, these interfere with travel. The remote first aspects to this travel are not as affected so much as patient first travel. So it's easier to get it's easier to get a bot across a border than it is to get a body across a border. That's the bottom line there. Secondly, that there's a huge difference in acuity, complexity. So somebody traveling from the UK to Turkey for a hair transplant is a fairly low acuity, low complexity service, and it's basically cosmetic and completely voluntary. On the other hand, a family looking for the treatment of their son's cerebral aneurysm is a completely different story. It's a completely different market, a much higher level of acuity. And case one, where the service is highly elective, completely cosmetic, and non-life-threatening, the dynamics that affect that market are very, very different from the dynamics that affect the more urgent, highly complex type of procedure. In introducing your companies, and I had the pleasure of listening to several of these introductions, you, of course, talk about being able to do lots of different things. My experience is that the more you specialize, the more likely you are to succeed. So this next bullet about trade architecture talks about the channels in which you are active. So business to consumer teleconsults versus business to business exchanges versus digitally enabled travel. So all of those channels are engaged, but they're engaged in different ways when the consumer is elective and traveling at her own volition versus when the consumer is seeking treatment for a truly life-threatening condition. And of course, we're going to address the AI trajectory and talk about how AI is being applied now and how it might be applied in the future. Okay, I'm going to try again. Let's see if this works. No, it does not. Okay. The point being made here, the underlying point, is that cross-border trade is now multimodal. It's not just a consumer traveling across a border to consume care and then returning back to where he or she came from. That the General Agreement on Trade in Services, or GATS, talks about there being 4 modes of cross-border trade. The first mode, or mode 1, is when information is exchanged across the border. The oldest form of this being radiographic studies who were done somewhere, and then they were sent somewhere else to be read, studied, and a report generated, and then sent back to the patient doctor's location for interpretation and further resolution. So that's one of the oldest forms, but this is now growing with teleconsults, second opinions, mental health interviews, follow-up, and even digital therapeutic procedures, remote patient monitoring. These procedures can be business to business, where you have teleradiology, tele-ICU, pathology reviews, tumor boards, clinical mentoring, even remote robotic surgery. So I would call that a second category of business to business, or mode 1 cross-border trade. Mode 2 is what we're all used to talking about. When people in this group have been, and you've used the term over and over again, medical tourism, what you're thinking of is an individual crossing a border to consume care and then returning to his or her domestic location. We've seen how that's disrupted, and we are also now seeing how that one mode is changing. It's morphing. It's shifting into a far more amorphous. It's much more flexible, and we'll go over why and what that means. But modes 3 and 4 involve the platform, people, licensed clinicians traveling to a location to either teach or be taught, or to provide direct services. Hospital networks where hospitals are across borders. Digital brokers, such as some of you are digital brokers, and AI-enabled navigation teams. Okay, so if I can have that, I think Dr. Ferrani's controlling the slides. Okay. Yes, of course. Of course, it'll be shared. Low acuity services are the easiest cross-border digital exports. So low acuity or low complexity care, where the consumer is the patient, in that situation, it is the easiest form and most amenable, most easily adapted in digital environments. I build a website, it attracts consumers. Consumers choose where to go to for their cosmetic dentistry, their hair transplants, their cosmetic surgery. They want to go to Korea for the K-pop look, and they develop and secure that relationship almost completely virtually. That is, by definition, a digital exchange until the consumer actually travels to the destination for care and then returns to their home or where they came from. So the best fit services for these high acuity, and by the way, for these low acuity services, cosmetic procedures, by the way, there's far more cosmetic procedures and elective procedures than there are exigent or urgent procedures. Many more people look for cosmetic procedures versus the number of people looking for hip replacements or for the resolution of an abdominal aortic aneurysm. So primary care, urgent care triage, dermatology, behavioral, fertility counseling, nutrition, rehab. These are scalable. And why it scales is important. This is important for how you build out the attraction. If you're attempting to build a market for these services, how it scales and why it scales becomes important because cross-border trade can be facilitated by effective social media marketing, can be facilitated by effective websites, and it can be augmented by intake transmission, facilitating emails, etc. There's not generally, for such procedures, there aren't big files like medical records to be transmitted. There aren't multiple, the situation isn't fast moving, as in many cases, high acuity or complicated medical care seems to be. So for low acuity or low complexity services, the digital environment is much better suited. Would you, next slide, please? So going forward into the future, we're going to find that digital services will wrap around physical services. We're already starting to see this, and we will see more of it. Certainly, travel still matters. You have to go somewhere for surgery, particularly for solid mass tumors, for transplants, complex cardiology, and rare disease interventions. These require physical infrastructure and multidisciplinary teams. Many of you have talked about the infrastructures that you have constructed around your medical travel, your cross-border trade offerings, and makes perfect sense. Digital adds value both before and after. So the digital before, as you all know, is the teleconsult, it's the interview, it's the sharing of the file, the review of the file, the review of the initial examination. I'm thinking of dental implants and that type of thing. This is all extremely useful. And the other advantage to this digital environment is that because the governance burden in high acuity or complex care is higher, these can be facilitated extremely well digitally. This didn't used to be the case, and we should all be taking advantage of this as we go forward. Next slide, please. So I've done a table here, and yes, you'll be, I believe, Dr. Farani, that the people will be given this deck. I've looked at the low acuity versus high acuity, simple, elective, not complicated, versus urgent, life-threatening, and complicated, and done a side-by-side comparison. And if you go down to margin driver, what I mean by that is where the profits are. Many of you are straight up business people and you're concerned about where the profit opportunity is. Well, in low acuity, the profit is in repetition. It's in doing the same thing over and over and over again, doing it frequently. That's not the case in complex care because, well, it's just not that many. There's a lot around the world, but there's just, in comparison, far fewer, as I said, abdominal aortic aneurysms than there are people looking to get their bald spots filled in with some cosmetic hair transplants. So the role of digital in this trade is to convert, triage, and manage the outcomes. What's really important here, I think, is that the markets for, especially for lower acuity and even moderate complexity procedures like orthopedic procedures, the market in fulfillment, the providers that are doing it, have done a very good job of attracting the consumers. You all do a wonderful job of holding their hands, so to speak, and bringing them through the procedure. The real hole, the real gap in this is afterwards. What happens afterwards? For many providers, when the provider walks out the door and the door closes, they're very happy to be done. However, the more complicated procedures, and even the not so complicated procedures, follow-up, follow-on, follow-up monitoring is a missing critical link to building and securing lasting relationships, both in a geographic market with a group market, people are markets. And if you're working with providers, it's extremely important for the providers. And if you're working for insurance companies, it's extremely important for them as well. So would you, the next slide, please? So this is just some data about what's occurring in OECD countries. That's the club of developed economies called the Organization of Economic Communities, Developed Communities. So the average teleconsultations was 0.5 per patient in 2019, and it grew because of the pandemic to 1.3. It's back down to 1.0. There's some resistance to teleconsultations, particularly among older doctors. And in all of the developed economies, all the doctors are old, unfortunately. In the Islamic countries, the doctors are much younger on average, so you have an advantage there. The availability of digital health services has also changed. It was 82% in 2024, up from 79% in 2023. What's clear about all of this is that consumers want, especially at the lower end, but throughout the profile of consumers, they want digital health. They want to be able to call their doctor by a video, by FaceTime, by WhatsApp, see the doctor, talk to the doctor. They want to be able to talk to the discharge nurse and show her how the wound hasn't healed and ask her what that means. They want to have this follow up, and that's critical. Next slide, please. So there are many questions about artificial intelligence. Most of what you read about artificial intelligence is opportunistic scaremongering. So this is companies trying to make you scared by talking about what AI will do to you. And the truth is that AI is not yet ready to do anything to any of us. However, we can use it. And healthcare is using AI. So most of the time when we talk about artificial intelligence, we're talking about what's generally understood to be large language learning models. So Claude, Perplexity, I use Perplexity, Claude. These are tools that rely on all the available words and information and graphics that are available on the internet and other places. And these tools scrape or harvest that information for our use. Another example is within a hospital, all of the medical records within a hospital can be scanned, and the tools, the algorithms, the arithmetic formulas can look at which cases of abdominal surgery produced a good outcome, which ones didn't, and inform the clinicians about potential risks, inform the clinicians about what types of dressings or pharmaceutical treatments were most effective in this particular type of case. And it's able to be used by clinicians as a guiding tool. So that's clinical support. Before that, of course, there's the administrative layer, as the slide says. The unfortunate thing about much of this administrative and clinical information is that it's based on mostly mostly people from the West and mostly people who look like me. And that is not, so the information is biased. And we need to understand that. We need to be scrupulous about using it. So how are we using it in cross-border trade? Well, the translation tools in the large language learning models like Perplexity, like Claude, like Copilot, the translation tools are terrific. They are far, far better than they've ever been. The other is patient matching, and you may not have this you may not have this need, but there are significant situations where for treatment of high acuity services, complex services, you need to do matching of blood, of tissue, etc. Pathway navigation and remote monitoring. All of these digital and AI-enabled tools make cross-border trade much better and adds real value to what we're offering to either our business to business customers or to our direct to consumer customers. May I have the next slide, please? So AI is certainly going to have an impact, and most of the time, and forgive me if I'm speaking to people who are truly expert in AI forgive this. I'll just say in general, most of the time we're talking about large language learning models like Claude, Copilot, and Perplexity. When many people talk about AI, they're talking about agentic AI, as in AI becomes the agent, where the AI, the computer algorithm, the formula, decides what it's going to do. So the difference would be in matching a patient to a donor. The difference would be the difference in an LLM and a large language learning model. The formula would give you exactly who matches. In an agentic AI, it would tell you who the tumor, who the kidney, or who the blood, or who the bone marrow should be given to. So there's a big difference between those two, and AI isn't there yet. So the likely next wave functions of these large language learning models are intelligent referral routing, determining where a consumer is most likely to receive the service or solution that he or she is asking for or needs. And that's a big difference than leaving it up to the consumer. Automated case packaging for payers, ministries, and international patient centers. So embassies want to know how much it's going to cost. They're going to give you, if an insurance company is talking with you about a guarantee of payment, the GOP, the package needs to be decided in advance, and that is a great role for LLMs as a tool. And digital twins, which is another very, very high level sophistication. I'm moderating a panel in New York City in September about this. Digital twins is just what it sounds like. I can make a digital twin of Dr. Farahani, and I can determine in advance which types of molecules will be most effective against curing that incredible smile she has all the time, or not, as the case may be. Predictive monitoring after discharge. This is a gap which I can't emphasize strongly enough across all of the markets. I don't see providers or facilitators following up with their consumers or their providers after the consumer has completed the treatment and returned to her home. Okay, the next slide, please. The guardrails, the tools, the cultural and systems guardrails that will be in place and are only just beginning to take shape is the human accountability for high-risk decisions. Humans play a central role. Each of us is a human. I don't think there are any AI bots on this call, but maybe there are. Each of us is a human, and each of us has a responsibility, and with that responsibility should go accountability. Very often in the countries with which we work, these are some of the earliest and most important suggestions that we make, that there be credentialing, certification, and oversight of those involved in making arrangements to transfer or work with consumers from one destination to another destination. It takes a certain level of both accountability and systems to make sure that when errors occur, it's not if errors occur, because of course there will be errors. There, even in the best run systems, 10 to 20% of the more complex procedures will result in untoward outcomes, and there needs to be oversight of those. So we're going to have, in the future, we're going to need interoperable health data. This is a nightmare, or is a quagmire of complexity at the moment. Health systems don't talk to each other. Oftentimes that's within the same country. Private systems don't talk to public systems. Clinics don't talk to hospitals. The doctors don't talk to the hospitals or the clinics. So it's a real nightmare. And my belief, my hunch, and what I read and see in my work around the world is that there are some very serious people working on ways to harmonize and synchronize data. So this is an extremely useful future for us. And this is all the way from harmonizing pharmaceuticals to harmonizing what people call the certain steps in a procedure. They're not the same country to country, region to region. And procurement models will be changed by digitization and digitalization of the processes. The procurement models will be changed, and we need to be ready for that. Embassies, payers, third-party administrators, these will apply screens, filters to who they choose to work with and who they don't choose to work with. And we can anticipate that if we are, a lot of us on this call are facilitators, brokers, agents, and we need to anticipate that by asking in advance and helping to manage that transition. Next slide, please. So what are the strategic messages? The first is telemedicine is not a side product. It's the liquid it's the solvent that penetrates all of the verticals and will continue to be a pivotal element to our exchanges. I guess the best metaphor is that telemedicine is the enzyme to the reaction of cross-border trade. We need to build separate models by acuity. The model you use for hair transplants cannot be the same as the model you're using for hip transplants or even for solid mass tumor surgery. They're very, very different. And then we're going to invest wherever AI adds value. And I've tried to point out that the way it will add value is determined by the channel in which you are working. Okay, and the next slide, please. And that, my friends and colleagues, is my presentation. There is a few minutes, and I will say this out loud. I made an error in planning the time here, so I'm making this question and answer time available to you. If you don't have a question or you think of a question after we're done, this happens to me all the time. I should have asked her this question. If you think about that afterwards, here are my contact details. Please do be in touch with me. But I'll be very happy to try to answer any questions that you all have.
Thank you very much, Dr. Irving, for such a practical and forward-looking session on digital health and telemedicine, and also for your valuable insight on how digital trade is transforming care pathways, and also on your perspective on cross-border care as a multimodal trade model, and all the information you provide about future of AI and a strategic message for leaders in the field of healthcare was truly eye-opening, and this is exactly the kind of strategic thinking our industry needs as we continue expanding across the borders.